Hello, I'm Dr. Nour Marshaha from Syria. I'm here to talk about simplifying dental aesthetic complexity. Cosmetic dentistry became highly desired by patients due to the nearly ideal end results seen in the famous before and after pictures. But behind this perfect after picture, there's a lot of hard work, including planning, treating, and communication done by the dental team. My goal in this lecture is to simplify these complex and challenging cosmetic cases with the aid of real life cases from my own practice. A smile reflects person in yourself. A sparkling smile in harmony with lips and face crowns the beauty of that person's character. As each smile is unique to that person, a beautiful smile should be one that is so suitable to the face and character of that particular patient that it appears to be perfectly natural. Before starting any new aesthetic cases, what you should know before starting any aesthetic case: how to evaluate smile analysis, what to expect of any case you face it, how do you select a good choices options, how long will my plan last, what about payment options, what type of maintenance is required. Smile analysis points: teeth, gum, breathe, face. Sting, go away. How you can achieve a brighter smile. Solutions: 1. Polishing. 2. Bleaching. 3. Composite. 4. Veneers. 5. Crowns and bridges. 6. Implants. Bleaching. Tooth bleaching is one of the most conservative and cost-effective dental treatment to improve or enhance person's smile. However, tooth bleaching is not risk-free and only limited long-term clinical data are available on the side effects of tooth bleaching. Accordingly, tooth bleaching is best performed under professional supervision and following a pre-treatment dental examination and diagnosis. In consultation with the patient, the most appropriate bleaching treatment options may be selected and recommended based on the patient's lifestyle, financial considerations, and oral health. So, when we will do bleaching treatment, we have general considerations. A typical dental examination begins with a health and dental history. Intraoral examination of the heart and soft tissues of the mouth and extraoral examination of the head and neck are also conducted to assess the patient for oral health problems, as well as lumps, sores, or other signs of disease such as cancer or infection. And we should, the patient history would include the patient's opinions regarding the cause of the tooth discoloration, right? So a history of allergies and sensitive should and all information regarding any past problems with tooth sensitivity. So, some tooth discolorations may be the result of disease or condition that requires endodontic therapy, restorations, or dental surgery. Such diagnosis can only be made by dentist or another licensed healthcare professional, depending on local licensing regulation. In light of these and additional factors noted below, a dental examination with appropriate radiographs or other screening or diagnostic test is recommended prior to considering tooth bleaching. Always, patient habits and lifestyle, as well as the presence of removable or fixed appliance or prostheses, should also be. Dentist managed bleaching treatments may include in office bleaching or at home, use of home bleaching trays at night or during the day, or strips, paste material, or a combination of these treatment methods. The choice between the methods and types of products related to many factors, including the patient's lifestyle, caries history, tooth sensitivity, and discoloration type, Additionally, the need for an effectiveness of maintenance or and we can see in this case before and after. It's okay to take pictures just to assess the result. Composite fillings. Professional dentists use rubber dam, so try always to do your best and use the right way just to get the best results. Composite filling. Composite fillings. Composite fillings used for repairing chipped teeth, closing space between teeth, cracked or broken teeth, decayed teeth, worn teeth, for mock-up, anything you want to use the composite filling, you should know how to finish the composite filling in the right way and you should apply it well. Okay? So when we'll do finishing composite, we should make sure that we make it well and we make it the same of adjacent teeth. Um, why is finishing and polishing the composite fillings is so important? It ensures the oral health and longevity of restorations. A smooth surface reduces the plaque. This leads to healthier, longer lasting restorations. A smooth tooth surface minimizes gingival irrigation and surface discoloration, so the health of gingival tissue is maintained. A highly polished tooth surface increases the reflective and refractive index of the restoration to create more natural and aesthetic smiles. If proper technique is followed, finishing and polishing greatly enhance the longevity and long-term wear resistance of the restoration. Finishing and polishing enhances patients' comfort and satisfaction, and patients generally appreciate. So the key of the beauty is final steps of procedure. Always make your work perfect, and the perfect composite fillings doesn't need finishing. Each case of aesthetic dentistry is a work of art. The dentist's perception, talent, artistic flair, and skills in listening to the specific desires of his or her patient help to create a smile that suits the face and personality of each individual patient. If this were not so, all smiles would only be impersonally constructed prototypes. The traditional rule of the dentist in the past was to correct or repair the teeth. Today, aesthetic dentistry has changed the lives of hundreds of thousands of patients in a positive way. So, we should understand the components, elements of smile design. It has been found that attractive people tend to get the better job. As an attractive smile has always been the focal point of attention in any aesthetic procedure, the aesthetic dentist seeks not only to improve the aesthetic appearance of the patient, but also to improve the patient's self esteem. Better smiles are being equated with better living. A beautiful smile seems to reflect a certain style of living. In the past, the achievement of either aesthetics or function required the sacrifice of the other. Whenever function was predominant requirement, aesthetics has to be compromised. Today's materials and treatment approaches permit the clinician to achieve both goals simultaneously. Now we're going to talk about veneers. Veneers, it's a thin layer. It can change the shape and shade. As a successful architect takes various aspects into consideration while designing a building, similarly, the aesthetic dentist must focus not only on form and function, but also the personality, gender, occupation, and even the lifestyle of the patient. The smile is reflection of that individual. It's important. Therefore, to communicate with the patient about all aspects of the treatment. So, aesthetics, more than any other area in dentistry, is based on individual perception. The restoration of the clinician is generally the most important factor in success. We should focus on aesthetic and function. The veneers is a layer of tooth colored material that is applied to tooth, okay, to change the shade and shape. And nowadays, the procedure of aesthetic dentistry, it's safe, highly aesthetic, less work time, and firm fit. We all know the indications and contraindications of veneers and why most of the dentists don't plan their work before starting. Why you don't design your work before building. Excellent work has been defined as the profession of good qualities or skill in an eminent or unusual degree. So, the aesthetic dentist should be willing to expect excellence as a final result. And we should create restoration harmony in the size, shape, and arrangement of the teeth are required in order to enhance each patient's features. When a patient arrives for aesthetic treatment, they are usually motivated about beginning the process. But you should try to make these plans and listen to your patient's desires and what they're saying about their post-operative expectations. Respect their desires and ideas and try to achieve it. We have smile styles and proportions. Try to choose the style as your patient desires and personality and lifestyles, and try always to study your components of the smile before starting. Golden proportion, we know that the golden ratio is, or as it's known, golden selection or proportion. It's around 0.618 for height to width ratio that measures. Okay, so everything in this word, everything beautiful, should make this proportion. But in dentistry, they see that this proportion, it's not perfect always. So we depend on another proportion, it's red proportion. Red proportion, we can make the teeth between 70% to 90%. 70% means that the teeth is more longer, 90% the teeth more squared. Okay, so the perfect and ideal proportion for red proportion, it's around 78 or 80% off. So this, we will focus on it when we will do digital smile design. If the central is 100, the lateral should be 75% of central and canine should be 50% of the central. Preparation of veneers. We can see the difference between prepless veneers and traditional veneers. It must be done with skill and meticulous attention to details for everything else that follows: pulp vitality, periodontal health, a good aesthetic result, proper occlusion, protection of remaining tooth structure, and the longevity of the restoration itself will depend on it. We can do distinguish between prepless veneers and traditional veneers. Prepless veneers, it almost be done with the minimum reduction of the tooth structure around 0.3 millimeter, and traditional veneer will be more than 0.4 on the cervical and 0.6 on the incisal and more. Preparation of veneers. we can see that it's 0.6 millimeters minimum tooth reduction. Proximal contacts may be maintained or the preparation is extended to the lingual surface. Margins are not placed at eccentric contact points. We have three types of preparation of veneers: flat incisal edge, over incisal edge, window. For, for window preparation, preferred indirect composite veneers preserve lingual and incisal surfaces, significant occlusion function, preservation of functional surfaces, reduces wear of opposing tooth. About incisal lapping design or flat incisal edge, lengthening of tooth, we can make it longer. Incisal defect facilitates seating of veneers, lower anteriors not veneered. How many visits we need for the veneers? We usually need 3 visits. First visit, we would discuss with our patient about the smile analysis and we can send the design to do wax up or mock up. Second visit, we should try the mock up and see if it's okay with the patient and it's achieve the desire of the patient. And then we can start preparation on mock up just to reduce the reduction on tooth structure. Third visit, we can try the final veneers or final restorations, and if we see that it's okay, we can cement the new smile makeover. The best smile possible. There are some of the things can do. When you see the patient, listen, discuss, and write down the patient's wants and concerns. Show them samples of crowns and veneers. Show them some before and after photos of restorations your office has already done. Ask them if they desire their new teeth to be whiter and go over the different shades. Sometimes patients regret. Right. Regret. Sometimes patients regret not choosing the new crowns to be whiter. Assistants can help them to make this decision early in the treatment planning. If they want their natural teeth to match the new crowns, explain the whitening process, explain the prep appointment, temporization, and final cementation, go over the time each takes. Take study models and bite registration, take digital photos, take radiographs. Preparation of veneers. Usually tooth preparation can be divided into 4 parts: labial reduction, interproximal extension, cervical margin placement, incisal preparation. So length, contacts, and incisal shape. Veneers length relative to the prepared tooth, contact zone, long or short, tooth shape, tapered, square, incisal shape, round, square, variable. Preparation of veneers, we can see that there is preplus veneers and traditional veneers. What's the difference between them? We will know. It must be done with skill and meticulous attention to details for everything else that follows: pulp vitality, periodontal health, a good aesthetic result, proper occlusion, protection of remaining tooth structure, and longevity of the restoration itself will depend on it. Okay, see that when we do uh, veneers, the minimum thickness is 0.6 millimeter, minimum tooth reduction. Proximal contacts may be maintained or the preparation is extended to the lingual surface. It depends on your case. If you don't have caries, if you don't have space, you should not do preparation in the contact area and arrive to the lingual surface. I always prefer to keep contact natural if we don't have problem, but if we have spaces, we should do the reduction to the lingual surface just to give the technician the ability to close the spaces between teeth with just to make the spaces better. Margins are not placed at a centric contact point. We have three types of preparation of veneers: flat incisal edge, over incisal edge, and window. We should know the indications for each one type. We can see that flat incisal edge are the first pictures, over incisal edge, and window. Okay. For window preparation, preferred indirect composite veneers preserve lingual and incisal surfaces, significant occlusal function, preservation of functional surfaces, reduces wear of opposing tooth. So we prefer this one for composite veneers, and if we will not do the lower. About incisal lapping design, lengthening of tooth, this this design of or this kind of preparation of veneers help us to make the length as we want on our digital smile design. Incisal defect, okay, if we have fracture, if we have abrasion, anything, so this one will help us to its indication for incisal defect. Facilities, okay, I will do this one. Incisal lapping design, its indication for lengthening of tooth, incisal defect, facilities seating of veneers, lower anteriors not veneered. Preparation. I show you the pictures one by one just to show you the steps of tooth preparation for veneers, for traditional veneers. If you will do the prepless veneers, you should focus to work on by using microscope or high magnification like loops, microscope, whatever. If you want to do traditional veneers, you should prepare more than 0.6 millimeter. Okay, see the vertical preparation methods. I will start with these pictures. Create the cervical margin first with controlled reduction parallel to the gingival half of the fascial surface. Use this pen, pair. This will make your work supragingival. I prefer to make the finish line supragingival because our patients in our country not taking care of their oral health. They don't have good hygiene. That's why I prefer to make a supragingival margin. Create the cervical margin first with controlled reduction parallel to the gingival half of the fascial surface. Then you will see the movement, how the burr work. Try to make your hand strong and stable. Okay. Create the second plane with controlled reduction parallel to the incisal half of the fascial surface. When MR gauged diamond ray reaches its full abrading depth, the guiding pen will rest on the external tooth surface. Okay, you can see the movement, how it's going on. Step by step, just try to do it the same. You will achieve the perfect preparation. See how we achieve the incisal reduction by the same burr, okay, and then see the contact. If the finish line required to be subgingival, move the rotating diamond to where the gingiva while the pen is kept in contact with the external tooth surface. The guiding pen can enter into the gingival sulcus up to 1 millimeter. Okay, see, then we are done the preparation. Okay, the guiding pen can enter into the gingival sulcus up to 1 millimeter. Things to avoid: rounded edge, undercuts, insertion access. Rounded incisal edge. This type of preparation with rounded incisal edge may cause hang-ups or chipping of the margin. No undercuts. Always place centrals, then laterals, and so on. How to handle incisal edge, path of insertion. This one unrestricted, the first picture on the left, and most common, that design in the middle. I prefer to do finish line in the lingual, by the way. It's better for the long result, for the success long result. The facial depth cuts are removed with a diamond burr, and the long axis of the diamond burr is ruled into the proximal chamfer area to eliminate any sharp line angles. We can see the difference between good prep, bad prep. Always do your preparation on animal as you can, okay? The difference between prepless veneers and traditional veneers is the depth. So when you will use prepless veneers as your case indication, you will prepare your case 0.3, 0.5, 0.3 on cervical reduction and 0.5 on incisor reduction. If you will do traditional veneers, you will prepare 0.4 for cervical and 0.7 for incisor. If you prepare your tooth exactly like your depth, your kit you have, you will achieve the brighter and the perfect shade and shape. Why? Because the shape depends on light. So try, for example, to put something in front of light and try to move the light around it. You will see the shape in a different way. So when you prepare your tooth in a perfect way, you will achieve the perfect shape and shade. Okay? Just remember that your preparation reflects the results. And when you finish your preparation, you should do the finishing, make it polished, perfect. Okay, we can see the proximal preparation. Correct proximal preparation, it should be points between the anterior teeth. Okay, I usually insert double zero when I will take the impression and triple zero when I will do preparation for veneers, for prepless veneers. So we have double, 0, 1, 2. It depends on your case and how much you will do the preparation. So we can see the difference between 0.4, 0.6. For profound color change, 3 shades or more, all teeth expect mandibular incisors at least 0.4 millimeter in the cervical area and 0.6 millimeter in the incisal area is indicated. 0.5, 0.7 when you will choose the color more than 3 shades of the natural teeth. Die spacer, this is space for cement, okay? Try always to make it thinner because as we know, if we have two polish glass, okay, we can achieve the perfect stronger connection between them. But when we put some sands between them, we lost the connection. So when you do perfect preparation and you finish your preparation and do polishing, the veneers will contact the tooth with a thin die spacer and good cement material perfectly. We can see this case after try-in. روقي 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 شوفي على مهلك دموع الفرح مبروك يلا ورجينا ورجينا قولوا خلاص يا ربي شوف والله رح تبكينا معك خلاص أنا رح أبكي. Try always to desire. Okay, we can see some cases. This case for four anteriors for upper and four anteriors for lower. Um, just achieve the function and aesthetic together in your work. Focus on gingiva, focus on digital smile design to achieve the brighter smile. We can see that diastemas in the aesthetic zone are anesthetic. All diastema should be closed. We can see some artistic picture. Okay, when we use microscope, we can see better, we can do better, we can achieve the perfect results. So this is the porcelain veneer kit I always prefer to use. Generally, a depth of 0.2 millimeter is needed to change the hue of the tooth by one shade. If you want to change A4 to A1, you should prepare the depth 0.9 millimeter. If you want to change A2 to A1, you should prepare 0.5 millimeter. A1 or keep the shade as is, it's enough for the 0.3 millimeter. Always try to use high magnification when you will do preparation. The dentist is the architect, the ceramist is the builder. Now we're gonna talk about the mock-up. Additional wax-up, silicone guides and corresponding diagnostic templates are very helpful for the dentist to get a preview of the aesthetic and functional outcome of the case and also for the patient satisfaction, okay? To get an instantly better preview of what the eventual outcome will be, the composite mock-up is wonderful as an aid to get the visualization result. So the step-by-step procedure to get clean, useful mockup is described as follows. A very clear chief complaint of the patient, the pictures of the patient, extraoral and intraoral, stone cast for both arches, intermaxillary registration, the aesthetic analysis of the patient, the smile design construction, digital manually direct, the wax up based on the smile design analysis, and also impression for the wax up, the transfer of the wax up inside the mouth, validation of the mocap together with the patient. So, the power of mocap is given by its precision. A precise mocap is the result of precise wax. We must take a good impression of the wax up and a good transfer composite material. In this short videos, I'll show you how I can do the mock-up on patient and transfer the wax up from the model to the mouth of the patient. I need heavy, putty, and light, and Luxa temp composite. The chief complaint of the patient for this case I will show you was I would like a bright smile and more beautiful smile. So in this case, I was need to do gingivectomy, but I didn't do anything. I just do mock-up just to show her how the smile will be if we do gingivectomy and arrangement of the teeth by veneers and crowns. So based on the dentist analysis of the smile and the chief complaint of the patient, the clinica will provide the dental technician with all the information needed for personalized wax up, length, volume, shape, position, and etc. On the patient's wax up, the dentist will be able to check the quality of the result and do fine adjustments if necessary. Now the next level has to be very precise. The impression of the wax up, they get a very accurate impression of the wax up. At least two things have to be accomplished: a very well finished wax up and a very precise impression material. So for the impression of the wax up, I use Speedex, hard and light. This case I didn't use light because I just make it as a temporary, and I will remove it as in the same visit, okay? So this stage is very important if we want to obtain a very clean mock-up. If the silicone is precisely cut, there will be no excess in the composite material. You see, I try to cut the margin by a blade, and covering of the gingiva and the aspect of the mock-up will be very close to the final outcome of the restoration. The hardest of the set body offers real advantage to get a very accurate mock-up. As a technique to safely remove the buccal part of the silicone, I prefer to start cutting with a blade from the zenith points and then go into proximal to mesial and from the same point to distal. As a composite material, I used Luxatemp because it's easy to work with. It has enough working time and the gel phase offers enough time to remove the gingival axis. Nice glossy surface after the setting time, natural value of the material. This is the aspect of the mock-up. And no polishing procedures, we're done. I'll show you this video.
هاي الموك اب صار جاهز. هلا هي رح تتخيل مبدئيا كيف رح يطلع قص اللثه، كيف رح تطلع النيو سمايل تبعيتها، بعدين نقرر.
The gloss is important for the patient's feeling during the test drive of our smile design. Also, as it can be seen in the images and videos I show you, the gingival elements of the mock-up are very good and no excess of the material is on the gingiva.
حسيتي على قص اللثه انه الامور صارت احلى؟ لا احلى كثير. طبعا نحن لسه لا قصينا ولا عملنا ولا شيء. كيف؟ خبريني. جنن. مرة مصدومة.
So, the mock-up is simulator. Allow the patient to visualize the final outcome of the aesthetic procedure with color, change, and tooth format without any kind of dental wear being performed. Okay, I'm gonna talking about the impression. You know, it's the most important thing when we do the procedure to send it to lab. For impression, you should apply the retraction cord and placing soft wax in the lingual embrasures prior to taking the impression will minimize tearing of the impression in these areas. For when you finish your impression and you will do the temporary veneers, when it's necessary or desired, I try always to keep supragingival out of heavy occlusion and attached by soft etching in the animal, center of the tooth, away from any margin, okay? Try always to keep margin safe. Other methods can be used which include acrylic type indirect methods. And always I try just to make the temporary away of papillas. We arrive to shade selection. You know, this part is the most important part in our lecture because color is a language. Understanding color requires learning the language of color. It's frequently spoken, but often miscommunicated. Effectively, to overcome the challenges associated with shade selection in aesthetic restorative dentistry, it's essential to learn the science and art of color. It's a difficult task because color is an abstract subject matter. Individual differences in color perceptions may vary, since the eye is not the most reliable means for color analysis. So, we can look at this picture. We can find that the water has many colors at the same time. When we are talking about the color, we are talking about the value, chroma, and hue, and translucency. We can see that the water reflects many colors: black, white, blue, It depends on the things around it, and that's why the shape could be changed with shade. So, the clinician has mastered the art and science of color treatment planning, including the correct color and shade selection for each patient. The clinician has correctly communicated his treatment plan and shade selections with the lab technician. The laboratory technician has correctly interpreted the received information and successfully combined materials in the fabrication process to produce the natural appearance. The shade selection process, however, has become more complex. We should uh, we must be satisfied in order to achieve the aesthetic outcome. First one, analysis, communication, interpretation, and fabrication, verification. The challenges associated with shade selection in dentistry were first um, identified in 1931. It's long subject when we are talking about shade selection, but today I will just give you some tips around it and some easy tips to make sure that we can understand the color requires dimensions of color. So it's hue, chroma, and value, and translucency, okay? So, so when we take the shade, teeth should be clean. We should remove any other colors that affect the taking shade selection. View patient at eye level. Evaluate shade under multiple light sources. Make shade comparisons at beginning of appointment. Shade comparisons should be made quickly to avoid eye fatigue. Most shade guides don't cover all colors in the natural dentition. Okay, so we have bleached shades, dentine shades, custom shades guides. I always, when I take the shade for each one unit, I take the shade of the neck, body, and incisal. I try to make the shade as much as I can in like the adjacent teeth by taking pictures, shade selection devices, or composite, many ways just to make sure that the shade guide is true and right. There are three basic types of devices used for shade selection. That the most important point in shade selection is to understand the color. We can and photos. As my experience, I see that the photos is the most important things when I take the shade of my patient. Because case, I just take picture and I do distinguish between the two shades to get the perfect one. I take pictures with natural look and pictures with black and white just to know the hue and chroma and value translucency of the shade color. We should, after do preparation, I usually take the shade before start preparation, and after preparation I take the ND color, and then I choose the desired color to send the order lab. When I see it's not right and I'm not sure of the shade, I just use composite fillings and put it as a spot points just to check which color is perfect. Especially when I do one unit, just to know exactly color of the neck and body and incisal of the tooth. Write everything to your technician. It's okay to draw anything just to make sure that your technician is understand your desires. Try to do good communication and make it simply. It's most important to make the communication better with your technician. Send each unit with the shade guide for the neck color, for the body, for the light zone, for the stains you want, for the translucency you want, for light yellow, brown, whatever. It's okay to draw everything in the paper and send pictures and do. It's okay sometimes to let your technician see the case. no matter. But the only way to get a perfect result is to know your steps and then you will arrive. When I take shade selection and I will send order to lab, what I should write in order. So I will show you the lab prescription. You need a complete lab prescription consists of the following: shade of the prepared teeth, shade of the veneer, cervical body incisal, appreciate interface, space and dispacer coats, veneer length, contacts, incisal shape. Laboratory, in addition to the impressions, these things should be sent with a case. Have the lab do a wax up to help design the new smile. This is also sometimes to present to the patient to show them their potential smile. Digital photos that show full face smile, close up smile, right left side view of the preps, retracted smile view, photo with the temporaries, photo with shade tab. Necessary photos if needed. A photo from the patient of teeth they like from a magazine, family pictures, celebrates, whatever, by registration. Coordinate the patient to visit the lab for a shade match. If the lab is located locally, make sure to follow this protocol with provide the patient with best smile possible. And now I'm gonna talk about the try-in veneers, crowns, and bridges. Why it's very important to do try-in visits. Try-in help to visualize the final results of the shape and shade for the smile makeover. Decrease the chances of case failure. The patients get used to the smile new look. What's the goal of the smile design? There's three goals in smile design. One, to obtain input from the patient regarding their desires. Two, to transfer these desires to the ceramist. Three, to provide ideal aesthetic based on subjective criteria that meet number one. Always try to take pictures to show your patient the result.
It's very nice. هلا رح نشوف كيف كنتي اوكي؟ شكرا اسناني الحمد لله الحمد لله على السلامة كتير انبسطت لك طبعا لسه بس نزلت وطابت رح تصير كتير أحلى
Try always to make your name as a brand. A brand is the set of expectations, memories, stories, and relationships that taken together account for a consumer's decision to choose one product or service over another. A brand for a company is like a reputation. For a person, you earn reputation by trying to do hard things as well. Professional dentist use rubber dam. Try always to use right steps to get right results. For try-in, when you will do try-in visit, remove the temporary. If you spot bond the temporary in place, as I do, you will probably have to grind through the area that was bonded to allow for removal. Verify if area is clean. After removing the temporaries, it's extremely important to make sure all of the cement has been removed and the dentine is clean. Place veneers, check contacts. Once the area is clean, you can place the veneers on the prep and proceed to check the contacts and margins. At this stage, I simply try the veneers in dry. Once I know the veneers fit acceptably, I use water as a try-in base to evaluate color. If the water try-in looks good, I will use translucent cement to see the restorations. If the color is a problem, I will start trying some of the colored try-in pastes to determine which cement I might use. In my particular cases, I usually use Verling veneers too, and I prefer the translucent colors because for a lifesaver to brighten the restorations without making them appear too opaque. Now we're gonna talking about cementation. I just give you a simple tips for cementation. Preparing the restoration for cementation. Clean the restorations. The material of try-in will lead you to the clean of the restoration. If you tried with resin paste systems, you can clean the restorations with acetone or Cavalex. If you tried by water, no need, only you need to rinse it. It's good to clean with phosphoric acid, and that may can come in contact with bonding surface. So each with porcelain etchant, porcelain conditioners, 10% of hydrofluoric acid. The time of etch depends on the ceramic materials used. So first thing, you should clean the restorations after try-in. Second, you should do etching. And then apply porcelain primer or saline coupling agent. Use pre-hydrolyzed saline, which means you don't have to mix two components, usually contained in cementation kit, Nixos Care. It's applied with a brush. The coupling agent acts to wet the surface of the porcelain. The saline coupling agent is allowed to sit on the surface, usually for at least 60 seconds, but some are shorter periods. It depends on the material of your bond. It can be dried with a gentle steam of air. Don't rinse after applying the bonding. Set prepared veneer in a light proof box until ready for cementation. So first clean, etch, bond, and after bonding you should keep it in a light proof box until ready for cementation. Now, after prepare the restorations, you should prepare the tooth, okay? Prepare tooth for bonding. First, isolation. Second, clean. Three, place clear mylar. And it's the preparation. Also, adhesive, okay? We will see each step. For isolation, if you will cement more than multiple anterior units, there's no need to apply rubber dam. You can do isolation by cotton rolls, and the nurse will help you as cysts are usually sufficient for cementation. Clean the tooth surfaces with rubber cup or chlorhexidine soup, pumice mixture, and then rinse thoroughly. Place clear mylar strip between involved adjacent teeth to minimize etching and placement of adhesive and cement on the adjacent unbonded teeth. Don't veneers at a time. The sequence I usually use is both centrals first, then lateral and cuspid on one side, and finally the lateral and cuspid on the opposite side. Etch the preparation. The enamel is etched for 15 to 30 seconds with phosphoric acid, 35% off. Gel etches are easier to control. And then rinse in with water and air. After that, adhesive is applied to the surfaces of the preparation. In the Nexus system, this layer is air thinned and cured prior to cementation. In other systems, this layer may be left to cure during the cementation. It depends on your system of cementation. Apply the cement to the preparation and the surface of the veneer with a brush or plastic instrument. Light cured material are used for cementation since the veneers are extremely thin and transmit enough light. Most cementation kits now contain two viscosities of cement. Seat the restoration with a frame finger pressure and hold in place while the excess cement is removed with a sable brush. Light cure veneer from the facial surface for at least I don't think so this 60 seconds. I usually use 20 seconds, and it depends on the strong of the light cure and how many watts you have in your light cure and your system of your cementation. You can't overcure these restorations. Cure from lingual surface if the incisal edge is included in the restoration. Finishing and polishing procedure. Remove excess set bonding material with sharp carvers. Keep instruments stable against restoration and tooth surface to minimize soft tissue damage. Recontouring and occlusal adjustments of the porcelain are done with a fine diamond and high speed using water coolant. Any surface which has been modified with a finishing diamond needs to be polished. If no marginal wear present between the tooth and ceramic, finishing can be initiated with finishing carbides, discs, and rubber points. Each kind of restorations need its own cementation. You can check any company and you can see the materials. And now we arrive to maintenance and follow-up. Patient first visit after 1 week post-operative, then after 3 months, follow up your cases 4 times first year and twice in the following years. Within follow-up visit, monitoring oral hygiene habits of the patients is important. The soft tissue should be examined. Check veneer margins for over contouring and for the presence of gingivitis. If gingivitis is present, recontouring of the margins should be done and patients should come back after 2 weeks for double check. Small losses of veneer can be solved by polishing and recontouring. If the repeated attempts to resolve gingivitis fail, remove veneers. If any catch occurs, use fine diamond bar to remove it. Resin patch should be highly polished. Final accurate occlusal check. Avoid using scalers on veneer surface. Silicone polishing wheel can be used instead. In case of large losses, replace veneers. I always do maintenance of my patients. Maintenance and follow-up. Patients first visit after 1 week post-operative, then after 3 months. Follow up your cases 4 times first year and twice in the following years. Within follow-up visit, monitoring oral hygiene habits of the patients is important. The soft tissue should be examined. Check veneer margins for over-contouring and for the presence of gingivitis. If gingivitis is present, recontouring of the margin should be done and patients should come back after 2 weeks for double check. Small losses of veneers can be solved by polishing and recontouring. If the repeated attempts to resolve gingivitis fail, remove veneers. If any catch occurs, use fine diamond bar to remove it. Resin patch should be highly polished. Final accurate occlusal check. Avoid using scalers on veneer surface. Silicone polishing wheel can be used instead. In case of large losses, replace veneers. I just always will remind you to say to yourself, as Einstein saying, simplicity is deeper than complexity in cosmetic dentistry. Do simple, get natural results. If you change a smile, you will change a life. The most important cases facing us in cosmetic dentistry: 1. Dental fillings. 2. Diastema. 3. Spaces between teeth. 4. Teeth sizes. 5. Discoloration. 6. Solving gum problems. 7. Size or forms of teeth. 8. Problems of orthodontic problems. 9. Solve the problem of genetic loss of some teeth, aesthetically resolved. 10. Simple composite solutions. And 11. Problems with the mouth smell. For diastema, to solve the problem of diastema, we need to know the amount of distance and the condition of the adjacent teeth. Diastema can be solved by ortho and then fix the situation, or fillings, or composite cosmetic faces. Always make sure that your gum and periodontal is healthy around your restorations. Discoloration of teeth and solve the problems of deep pigmentation. For this patient, she complained that the smile is not beautiful in terms of shape and color. Diagnosis: discoloration after pulpal treatment and suggestion of bleaching solution for color. Solution: approve the proposed plan, teeth whitening and then laminated veneers on the centrals only to solve the problem of color. And you can see that the two centrals, it's almost the same color of the other adjacent teeth. Goal of smile design: it's important that when planning treatment for aesthetic cases, smile design can't be isolated from a comprehensive approach to patient care. Achieving a successful, healthy, and functional results requires an understanding of interrelationship among all the supporting oral structure, including the muscle, bone, joint, gingival tissue, and occlusion. The size of the teeth is inconsistent with the size of the base bone. We can see in this case how I prepared this. I will show you. For this case, I will show you the case again. If you see this case before, what you think that the problems here? We can check the gummy smile. We can see the spaces between teeth. We can see it's old patient. Her age is more than 60. There's no diabetes. There's no disease in her body. But she won't, her desire was to get a perfect smile. We can check the sizes of the teeth. We can check first the midline. Okay, when we put the midline, we can separate the smile for two equal parts. I can see in this picture that the right side of central lateral canine, it's okay to do veneers. And the left side, we can see the spacing, okay? The canine, it's in the right side, in the right point, we can see for digital smile design, but the central, it's not in a right point. So we can prepare the central more distally just to make a place of lateral and prepare the space for bridge to make the teeth like the same of the other side.
تصميم بوازن اهم شيء بالتحضير انكم تخلوا ايدكم على نفس محور، خليكم بنفس المحور بيقوم بيطلع الشغل صحيح. اوكي.
See now how we can take the CR before send it to lab. In this case it's so hard. So
اللي تعتبر صعبة طبعا. التقويم رفضوا انه يعملوا لها اياه بسبب وجود انحلال عظمي، وعمل التقويم 3 مرات. اعطيني جنب وجنب، جنب تاني. ايوه بطلعي، ايوه اوكي، ولقدام.
okay, this is the case how it was before, and we try to make it better after. This is the dry in.
إذا بتلاحظوا معي الحالة قديش بارزة وقديش الأسنان محورة متقدم. رح ندرسها هلا. بنشوف الحالة، طبعا حالة العروس مفروض انه نسلمها after 3 days او 7 days maximum. بهمني انه تعرفوا شغلة كتير. هلا رح اشرح لكم كيف بالضبط رح ناخد وضعية السي ار مثل ما علمنا امبارح دكتور زياد. حلو انكم تشوفوها بشكل عملي اليوم. رح ناخد وضعية السي ار، بنعمل المريض بوضع الاستلقاء ونطلب منه يرفع الدقن. You can turn off light. خليكي راخية راخية. اوكي اتس اوكي جود جوب. يلا ارخي 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 وسكري شوي شوي عضي شوي شوي عضي.
Okay, how we can do the CR. We put wax on the anterior teeth and we tried one more times just to get the right position of the CR, and then we apply the silicone bite material and take the bite again. And after that, we can connect the two equal parts of bite registration on the molars together and remove the wax. Okay, we catch it on both sides and remove wax, then connect the sides together. And again, let patient bite again and wait until it's harder. And then we will remove it and send this one CR registration to lab. You should take it if you will do more than a unit. If we do rehabilitation of the smile in multiple units, we should do perfect occlusion of the patients and make it natural. We are now take the points of occlusal before start preparation, and we should send all the points to the lab prescription before start preparation. We take the points, you can see, on the cusp, and then we mix alginate to take the case before for study model. Okay. And sorry. Continue for bite registration and other side. And we should apply the chim stock with handle. Don't take bite registration without handle. And this is the lab prescription to put points of occlusal for bite registration. Now this is the preparation. I just tried to do the preparation and be careful for the pulp. Here I put Theracle. I just prepared 4 units anterior for crowns. I usually for those protrusion cases, I take 3D X-rays just to check the root axil. And here is the try-in, crowns and veneers. And we can check the occlusal and we can see that the protrusion is better than before. How to evaluate any smile? Try always to make any complex smile easily as much you can. First, you should do treatment. Second, you should evaluate your smile. You should face it. You should put your points around this smile for each one unit. And side by side, you should put your lines to know where to go and how you will fix. This is after of this case. When to make a centric relation record, restoring all posterior teeth in one or both arches, restoring all teeth in one arch, complete denture. Use shim stock, okay, for occlusal testing. The thickness is around 8 microns. Teeth should be dried to allow articulating paper to make the teeth, to mark the teeth. Use the silicone registration material for bite registration. So first record the centric occlusion and send points in the lab order form. A physical record which by determining the jaw relationships allows for transfer of the upper and lower models to the articulator in that jaw relationships. Our patients should not only look good, but also eat well, speak well, and be able to express their satisfaction with restorative work. Another very important trend in dentistry nowadays is represented by the increased attention paid to the connection between periodontal and prosthetic treatment. This connection is the weak point and the place where patients most often notice that the tooth is fake. So, any successful in aesthetic dentistry should ideally have a skilled periodontist as a very good friend. More and more emphasis is being placed on pink aesthetics and the junction between the tooth and the gum. The aspects in which periodontics for aesthetic purposes can be, can be of great assistance are making correct gingival outlines with the symmetry of the central incisors and the gingival level of the lateral incisors below the tangent between the canines and the centrals. Making the correct gingival zenith, obtaining correct dental proportions, obtaining more thickness in the fixed gingiva in order to mask the dark color of the dental root through a thin periodontium. Principles of smile design, elements of smile designing. We should take care of the facial and the dental components. Always, there are two facial features which do play a major role in the smile design, the interpapillary line and lips. The interpapillary line should be perpendicular to the midline of the face and parallel to the occlusal plane. Lips are important since they create the boundaries of smile design. We have to seriously consider the correction of the facial composition before we venture into the correction of the dental composition. The smile is our business card. Try to make each smile of your patients as a business card. So, focus on smile arc, buccal corridor, amount of gingival exposure at smiling, presence of gingival and incisal asymmetry, presence of anterior superior diastema, presence of maxillary incisors ratio, size and asymmetry, among others. Smile evaluation is basically performed by clinical means such as photographs. I told you that photographs have always been gold, and try always to take the pictures of the complex smile. In classic term, the horizontal and vertical dimensions for the ideal face are follows the horizontal, and horizontal means that the width of the face should be the width of 5 eyes, the distance between the eyebrow and chin should be equal to the width of the face. Those all related to facial components, okay? And second is vertical. Vertical means the facial height is divided into three equal parts. The three equal parts start from the forehead to the eyebrow line, and from the eyebrow line to the base of the nose, and from the base of the nose to the base of the chin. The full face is divided in two parts, eyes being the midline. The lower part of the face is in divided two parts. The upper lip forms 1/3 of it, and the lower lip and the chin 2/3 of it. Okay, so the basic shape of the face, when viewed from the frontal aspect, can be one of the following. We have many type of face, like square tapering, and ovoid. And the lateral profile as following: straight, convex, concave. These factors play role in determining the tooth size, shape, and lateral profile. In short, the tooth morphology is dependent on the facial morphology. Vital elements of smile design includes the following: tooth components, dental midline, incisal length, tooth dimension, zenith points, axial inclination, interdental contact area ICA and point ICP, incisal embrasure, 6 personality and age, symmetry and balance. Contacts and embrasures should be between centrals 20% off, between central and lateral 30% off, between lateral and canine it's around 40 to 50% off, between canine and first premolar around 50% off. So older people's central incisors will be shorter and more square, and in young people the teeth will be more longer. Okay, the vital elements of smile designing includes the following. We said that teeth components and soft tissue components. The soft tissue contains gingival health, gingival levels and harmony, interdental embrasure, smile line. So the rule of each of the above mentioned factors in smile designing is given below. Evaluate gingival marginal position during smile asymmetry. Dental midline. So the dental midline refers to the vertical contact interface between two maxillary centrals. So if the maximum allowed discrepancy can be 2 millimeter. So the philtrum in interpapillary plane can be used as guidance to the midline assessment. The philtrum of the lip is one of the most accurate, and philtrum should match the papilla. Papilla and philtrum don't match, so a midline that doesn't bisect the papilla is more noticeable than the one that doesn't bisect the philtrum. To evaluate the midline, one must always consider the location and alignment. Midline should be parallel to the long axis of the face, perpendicular to the central plane. Over the papilla, the midline should drop straight down from the papilla. Face bow. In digital smile design, we depend on the digital face bow. So the midline in upper, it's not matched the midline of the lower teeth in 75% of the cases. So incisor length, take care of the degree of the tooth display, phonetics, and patient input. There are 3 smile levels: the commissure smile, the cuspid or social smile, the complex smile. We should do our digital smile design depend on complex smile. Try always to take video while taking the right smile of your patient, because the commissure smile, it's not real smile. The complex smile, it's the real smile of your patient, and we should depend on our smile design. Degree of tooth display, men show an average 1.91 millimeter tooth when lip is at rest, and women show more 3.4 millimeter tooth when the lip is at rest. Younger people around the 3.3, then older people 1.26 millimeter. So phonetics take care of M sound, E sound, FMV sounds, and S. Okay, during pronunciation, the mandibular central incisors are positioned 1 millimeter behind and 1 millimeter below the maxillary incised edge. Can showing different degrees of incisors exposure. Okay. Patient input. The patient desires must be met as best as possible. Okay, correct incised edge position, and all these factors play a dominant role in both aesthetic and function. Take care of aesthetic and function. Canine to canine or first premolar, the first premolar, that means aesthetic zone. Okay, where central incisors are known as the key elements and its dominance of central incisors. Take care of sex, age, and personality. And female form round, smooth, soft, delicate. For male, we should take care of the tooth shape between female and male, and personality also. The canine give us the personality character. So central and lateral incisors must range from 1 millimeter to 1.5 for women and 0.5 to 1 millimeter for men. And we can see the difference between convex smile arcs and more suitable for women, and design of teeth in aesthetic zone we can see. So I told you about the golden proportion, red proportion, and proportion, and chest gauges. And this is the video about the chest gauge. I always depend on this very, very good instrument when I just do designing and know exactly the proportion of the teeth while preparing or try in or do gingivectomy or crown lengthening. So also we have to keep in mind that central incisors is wider than the lateral by 2 to 3 millimeter and canine by 1 to 1.5 millimeter. Canine is wider than the lateral by 1 to 1.5 millimeter. Canine and central are longer than lateral by 1 to 1.5 millimeter. And always buccal corridor refer to dark space, negative space. Don't make it wide and don't make it narrow. Buccal corridor is not critical in smile aesthetics, and wide buccal corridor should be avoided, and maxillary expansion should be indicated whenever necessary. And now for gingival margin of central incisors, we can see the difference between classic and modified. The centrals will be below 0.5 of canine. Gingival exposure not greater than 3 millimeter. If it's more than 3 millimeter, it's not aesthetic. So we should take the interproximal contact point and contact area and make the teeth appear too uniform if we don't care about the incisal embrasure. The difference between strong and dynamic style depends on incisal embrasures. Try to make it in a right percentage between teeth. Symmetry and balance. We can see that the balance is observed as the eyes move distally from the midline so that both the right and left sides of the smile are well balanced. Gingival health. So try always to make it pink color and located interdentally 3 millimeter above the alveolar crystal bone. Located interdentally 5 millimeter above the intercrystal bone papilla. Should be pointed and should fill the gingival embrasure right up to the contact area. This is after crown lengthening in the same visit. Take care of the biological width. You can see the smile design video on YouTube and try to do the best that my design and how we can do the smile design digitally. You can see
هاي design template by Keynote on Mac computer. Okay, معكم دكتور digital smile design DSD and how to use it. أول شيء بيكون عنا template
and you can order the template from Dr. Mazen. I think he posted on the group of online dentistry on Facebook. Thank you for watching my presentation. I hope you enjoy it. Thank you.